So thank you for the opportunity to come and speak with you today. I'm from the Austen Bioinnovation Institute, which is in Akron, Ohio. And for context, Akron, Ohio is in northeastern Ohio. We're located in the county of Summit, so Summit County. Akron has a population close to 300,000, and Summit County has a population close to double that, which is 600,000. But our area in which we focus is really northeastern Ohio. So I'd like to share with you who we are, what we've been doing, and then also some outcomes of the work that we've been doing and then where we're planning on going. So let me share a little bit about the Austen Bioinnovation Institute in Akron. We refer to it as ABIA. So ABIA is truly a unique convergence. And within Summit County, within that part of northeastern Ohio, we have 3 independent health systems: Summa Health System, Akron General Health System, and Akron Children's. Those 3 health systems, though they compete, come together with 2 academic institutions, Northeastern Ohio Medical University and the University of Akron, to form Austen Bioinnovation Institute in Akron. So even though these health systems compete for the same patients in the same geographic area, they are leveraging their resources to commit to improve the health of the community. And also our larger goal, which is patient-centered innovation and commercialization. So with those 5 institutions, we have formed a 501c3, and ABIA is a 501c3. We also have some support from the county, so Summit County, the state of Ohio, the Knight Foundation, and also First Energy. So what are we doing? We're taking the opportunity by looking at the Affordable Care Act and accountable care organizations, and we're taking it further down the road. We're taking it to a different dimension. And what we're doing is called the accountable care community. And the overall vision of the accountable care community is to improve the health of our community. We do that by those core institutions that comprise ABIA, but as I'll show you in a few moments, we expand that quite significantly. So our key partner is public health, as well as over 65 social service, education, et cetera, type of institutions. So we're really focused on improving the health of the community, and we define that as population health. All of these institutions, and they're over 70 in number now, have come together to say we're going to collaborate. But to collaborate to us means 2 things. One is to give, and the second is to put things at risk. So we have the 2 sides of the equation. So you'll hear me share some information about how some of our institutions and organizations are leveraging their resources for the good of the accountable care community, and how some of those had made decisions to either sundown or to expand programs because that's what the community would benefit from an overall perspective. So it's really saying, let's look at each of our organizations and institutions, and let's follow our missions and what it is that we're doing, but then also bifurcate and do that in the dimension of what is good for the community from accountable care community perspective. Our outcomes, and I'll share some today, are the AAA of CMS, and then there are a few more beyond that. Things that are important to the area in which we live and also important to our stakeholders and others. We had placed together a white paper about a year or so ago, and that's the link for the white paper. It's also available via our website. That is a detailed explanation of what it is that we're doing, why we're doing it, and some of the outcomes that we have seen so far. We've been at this for close to 3 years now, so that's the timeline. So we're all familiar with ACOs from the Affordable Care Act, but what is the difference between the ACC that we have developed and are implementing and an ACO? Well, an ACO is usually dependent on a Medicare infrastructure. We're going beyond that. So not only do we have payers within, we also have public, and you'll see that we also have individuals that do not have insurance. So we're looking community-wide, irrespective of whether you come with a private insurance card, whether you come with a public, or whether you come no insurance, you're part of the accountable care community. The other thing is we have grassroots groups in addition to very large institutions that participate with equal seats at the table. and that's an important point. They're there in equality with all the other institutions that are working with us. And then we're not focused on who walks through the door of a health system. We're not focused on who receives care at our FQHC. We're focused on the health of everyone who lives within our population. And one of the three health systems coming together, one of the benefits that we have is if we look at individuals that live within our area of northeastern Ohio, the denominator of patients that are seen at those health systems is about 80 to 85%. So from an perspective, an epidemiological perspective, we have the denominator, or we have very close to the denominator to look at what it is that we're doing. So that's the difference between our concept of an ACC and the Affordable Care Act concept of an ACO. So I had mentioned some of our partners. Our other partners are Summit County Public Health, and in our part of the country, we have recently merged the city and the county public health, community legal aid, and if we're talking about determinants of health, it makes sense that community legal aid as well as other organizations and grassroots efforts are at our table. And we do have some money from the CDC through a community transformation grant, and I'll share a little bit more about that with you. So I had mentioned that we have over 70 organizations working with us. These 70 organizations we call the ACC Coalition, and we recently had a publication come out in Population Health Management that talks about how we had assembled these and put these together. But just very quickly, within our nation, part of our nation, we have a national park, the Cuyahoga Valley National Park. And if you think about what was the original mission of the national parks, it's public land for public health. So they're a key partner at our table because that's a resource for those in our community. Our public libraries is a resource and part of our coalition. Of course, our FQHCs, our other educational institutions, our faith-based organizations, etc. Together, they form the accountable care community, and they have all come to the table and said, we have a commitment to improve the health of the community. So what are some of our components? Well, if we have diverse health systems, you know that we have the issue of electronic medical records and non-agreement across those systems. There was a platform that was developed called Explorus that lets data from ambulatory centers, from hospital or inpatient centers, outpatient centers, and public health to be entered into a system, standardized across that system, and then collectively engaged across platforms. That's our data-driven mechanism that lets us collect, standardize, which is very important, and then also have available for analysis data irrespective of where it comes from. So our FQHCs, our free clinics, our nurse-run practices within the universities, as well as our health systems and others, are all part of that platform. Some of the other components, and I won't go through all of these, but impact measurements I'll talk a little bit more about, but also interprofessional teams is a core member of what it is that we do. So very quickly, what are the steps that we had taken? Well, we're really committed to the entire spectrum. So health promotion and disease prevention, access to care and services, and healthcare delivery. So all of the members of our ACC fall within one or more of those realms. First thing we did is we had done a very large community assets and resource, and we mapped that to the Frieden CDC Health Impact Pyramid, but we did that based on Healthy People 2020. So we took each of the metrics for Healthy People 2020, we took a broad-based examination of what is available in our community, we mapped it to the Health Impact Pyramid for each of those metrics for Healthy People 2020. And of course, we're trying to get things at the bottom of the pyramid. Where we saw that we had gaps, that's where we had come together to develop programs or to shift resources. So the community is now aligned based on Health Impact Pyramid for each of the Healthy People 2020 metrics. After we identified those priorities, we either shifted programs, shifted resources, or we developed new programs. We're looking at health outcomes. We're looking at for defined populations, perhaps by clinical states or geographic area or hotspots in our region, but we're also looking at it broad-based for the population. Of course, benchmark metrics, and then we're looking at economic cases because sustainability is paramount to what it is that we do. So we have cost avoidance models, and we have cost recovery models. And those models help to feed some of the money that comes back to keep the coalition and the ACC floating and going into the future. The CDC, through the CDC, we have a community transformation grant, and we're very much focused on programs as well as socioeconomic status approaches to the determinants of health along these 5 dimensions, which we know affect approximately 75% or more of our health conditions. Let me just give you outcomes for one particular disease, and this is diabetes. And our rate of diabetes within the state of Ohio and with Northeastern Ohio is probably very much familiar to you and also very much aligned with the rates within your community. So within Akron, Summit County, we're about 8 to 10%. So that's the area what we're looking at. And when we talk about the accountable care community, we're talking about prevention and health promotion for primary prevention, secondary prevention, and tertiary prevention. So our programs are not just focused on people at risk for diabetes or pre-diabetics. They're not just focused on people living with diabetes. We're really focused on the entire spectrum. So this is one of the initiatives that is broad-based, that touches every aspect of a health impact pyramid, and I've summarized just some of those findings for you. And one of the things I'd like to call to your attention is that I had mentioned that the ACC is not focused on a Medicare population, it's focused on everyone. And you can see from the results that I'm showing you, it's about a third, a third, a third. So a third of the results that I'm talking about are results that also for individuals that did not have insurance. And you can see these are about 2 years worth of data, that our cost for running the program is less than the national cost level. We have significant clinical outcomes, we have significant behavioral outcomes, and if we're looking at our health systems and we're looking at our payer systems, and patient quality, we have significant outcomes in terms of the things that we're trying to prevent from a tertiary prevention perspective as well as secondary and primary. What about those economic models? A return on investment. So the money that we invested within this approach to attack diabetes from the Healthy People 2020 metrics based on the ACC approach for the health impact pyramid, a return on investment study for over 2,000 individuals. And again, these are individuals that are at risk for diabetes or living with diabetes. We were able to save over 10% per month for the first part of that, and then over 25% after that point. So that shows, by looking at it from a population health perspective, not only do we have significant clinical outcomes, not only do we have significant behavioral outcomes, and also patient experience outcomes and community outcomes, we have significant cost savings. So if we think about broad-based coalitions, every one of those CMS outcomes or our expanded outcomes are touching what are important to those institutions, those 70 organizations that make up our coalition. These are some national data that you're all familiar with, and what I have placed at the bottom of the national data are our ACC results. So you can see that if we change the HbA1c values or affect those positively, what was our cost savings for our study? There's the cost savings. If we look at it from the perspective of the percentage of body weight that we were able to work with individuals to positively affect, there's our cost savings. We can also look at it in terms of ED visits, and we can also look at it in terms of the ACC values, which are at the bottom there. So in the blue are the national data that we all pay attention to, that we know is really what we believe is going on based on good scientific research. At the bottom is what we're seeing within our ACC. So you can see by looking at ED visits and cost savings, by changing body weight and cost savings, and by also looking at lowering HbA1c, we have a real cost savings coming out of the population health program that we have put together. Very quickly, what are some of our metrics for success? Well, the 3 from the triple aim for CMS is really what we're focusing on, but we also focus on some other things, like the IOM specific aims for 21st century healthcare. Those are part of our dashboard and what we look at. Things about patient safety, about determinants of health, care coordination, and many others. So we really have an extensive dashboard that really covers all of those metrics that are important to each of those more than 70 organizations that work with us. We also look at it broad-based. in terms of what we call impact equations. Because if we're truly focusing on Northeastern Ohio and trying to make it a healthy, broad-based community, we're very focused on what's the economic impact and what's the burden of disease impact. So we have two what we call impact equations, and this first one focuses on overall benefits and costs for our efforts based on a community approach and then a micro approach, which is a disease-specific approach mapped to Healthy People 2020, as an example like diabetes. So if we look at quality improvement, what we have done, the scope of the population that we've served, so how broad-based was it, and then the cost of our disease, we can assemble an impact equation to show globally how we are impacting our broad-based community. We also look at it based on the delayed progression of disease, especially if we're looking at secondary and tertiary prevention. So this particular impact equation is looking at burden of disease and whether we can either change the course of that burden of disease and the progression of disease or the impact that we're having. So it's a function of the delay of progression and also the total cost, because clearly if we delay the progression, there's an effect on cost. So those two impact equations let us look more broadly as to what are our outcomes and our successes, and then we also have those metrics that look very specifically as to what might be happening for an individual patient, individual practice plan, individual hotspot within our community. And then finally, I'll leave you with some thoughts regarding sustainability. One of the things that I had mentioned is we're very focused on what are those economic models, what's the possibility for cost avoidance and return on investment, because that's how we continue to fund the initiative from a broad-based perspective and continue to fund individual efforts, whether those are at the lower part of that health impact pyramid, in the center, or at the top. And that we really see that these systematic changes that we're instituting and our experience that we have is really moving collaboration to the norm. So now when we have our broad-based community events and we're talking about the impact and what it is we're doing, we're really shifting from a model of collaboration to a model of collective impact. And you see that based on our impact equations that we're looking at. We're also moving in the direction of having additional knowledge management tools because we believe that these are helpful in driving positive change. And then we're also working with our local government, state government, et cetera, to try to look at additional policies and procedures and zoning and planning that can help impact the health of our community. And moving them back to the direction, if we're going to think about it in that way, to health promotion and disease prevention, and also this continued coordination and perhaps more importantly, integration of public health, healthcare, social service, education, et cetera. And then we can't leave off payment reform. That's an important point. That's something that we've been working with not only within the state of Ohio, but also within our nation and our federal government to see how can we continue to sustain these efforts so that we focus on the entire spectrum, health promotion, disease prevention, access to care and services, and healthcare delivery. And finally, here are some references that sort of touch on those data that I had presented from you nationally, as well as some other thoughts. So thank you for the opportunity to spend part of the morning with you today, and I look forward to hearing the other panelists and hearing the discussion.